Thank you. Good morning. I appreciate your time. We're going to try to compress this just a little bit out of respect for your time. I'm Don Blanton. I'm board certified in emergency medicine and internal medicine. My career's been in emergency medicine. Was on the faculty at Vanderbilt when we created the residency program there in emergency medicine, and served as the medical director for the National Fire Department EMS system for a decade. And for the past couple of years, I've been working with hospitals and medical centers and medical staffs, helping negotiate all these transitions you've been reading about in the papers. We're going to talk today about ICD-10, but a whole lot more than just that. Risk adjustments, quality, cost efficiency analysis, the changing reimbursement environment, and literature review talking about how physicians define conditions and specifically the thresholds of severity within a condition and how those definitions are translated into credit toward our patient care. ICD-10 is coming October the 1st, no more delays. Big increase in the number of codes, diagnostic codes from about 15,000 to almost 70,000. That was a big deal for a little while until we realized that a lot of it was just adding left and right and the like. The AMAs dropped their opposition to it. Some important concepts: acuity. There are many conditions like heart failure, asthma that are chronic and ongoing. So when someone is admitted to the hospital, the coding system wants to know what changed. They had asthma last week, they weren't in the hospital. They had heart failure last week, they weren't in the hospital. Well, they're having an acute exacerbation. So we add the word acute, and with heart failure in particular, they like us to tell what the functionality of it, whether it's systolic dysfunction or diastolic dysfunction. We'll talk about that some more. There's a lot of increased anatomic specificity. Instead of just a neoplasm of the lung, it's left or right lobe, which bronchus, more than one, overlapping bronchus, left, right, bilateral. I think we got that. That's not going to be a problem. Episodes of care. There are 3 codes for episodes of care. The initial care is the active treatment phase. Subsequent codes are applied during the healing process, and the sequelae codes are applied after the healing is totally complete, but somebody, for example, may have a burn that has a contracture after the healing is complete that needs to be dealt with. So that will link it to the original injury or original event, and additional codes for everything else that goes on. Combination codes, the fast food industry is way ahead of us on this. We go into McDonald's and order number 1, we're getting a list of things, we know what they are. So the healthcare system is catching up there. Present on admission identification. Every ICD-9 code that every principal diagnosis and secondary diagnosis accrues, the coders have to declare whether it was present on arrival or not. Most of the time it's obvious. If it's on the H&P, the first problem list, that was obviously present on arrival. But sometimes things may arise during the course of hospitalization, and there's a fixed list of things called hospital-acquired conditions that if they arise after the inpatient order is written, we get dinged for those. Like if somebody gets a DVT while they're in the hospital, or a PE while they're in the hospital, or a stage 3 or 4 pressure ulcer while they're in the hospital, if it wasn't present on admission, then we don't get credit for that diagnosis, no additional resources, and it looks bad on paper. So by law, all diagnoses need to be made in ICD-10 coding after October the 1st. They've separated out the procedure codes. The procedure codes are used only by the hospital, so you don't have to worry about those for any procedures done in the office or even at the hospital in something other than inpatient status. So if they're in the ER and go home, or if they're in observation status and go home, those are not coded in PCS. CPT codes don't change. Physicians bill using CPT codes in the office and in the hospital. That doesn't change at all. What is going to be changing is how much money comes back to us from Medicare based on those CPT codes, and we're going to see how they're going to make those adjustments in just a moment. There are several versions of ICD-10. The World Health Organization has the basis of it that comes out of the box. It's like for an automobile, the frame, transmission, and engine. But many countries do their own detailed version, and the United States is one of them. These are the people that are responsible for our own version, called the cooperating parties. The CDC writes the diagnostic codes, Medicare, the inpatient procedure codes. If those function as if law, the American Hospital Association functions as if the Supreme Court to interpret the implementation of those codes. And they publish these interpretations in Coding Clinic, which the coders have access to via their computer modules. It's not going to be in any medical library. And then the American Health Information Management Association, the medical record people, provide input from the coding community. Now, there's another body of professionals very interested, very active in healthcare, not on this list. Anybody notice who's missing? There's no doctors on this list. And so you know what they say, if you're not at the table, you're on the menu. And so we have not been involved in the nomenclature of the administrative language to which our medical language is translated into, nor have we been involved in the assigning of relative weights to particular terms, and we're going to see examples of how that can be problematic. So why do we even care about this? Well, we're being evaluated now for both quality of care and cost efficiency of care. And those assessments are going to be made increasingly available to the public. The insurance companies already have these now. I don't know if you recall, about a year and a half ago, United Healthcare dumped thousands of doctors off their provider rolls because they were deemed to be cost inefficient. And these assessments are going to be increasingly linked to reimbursements, not just from Medicare, but from private payers as well. So, anybody's favorite radio station, KFI? It was on the radio when I was driving in this morning. It's not my favorite though. My favorite is WIIFM. What's in it for me? So we want to understand how this stuff affects us. This is a table that was published in JAMA, produced by the Center for Medicaid, Medicare Services, tracking about the transition in reimbursement over time. This is where we've been, fee for service, just volume-based exclusively. See patient, send bill, get check. Fee for service is going away. What they're doing now is basing at least a portion of payments on quality and cost efficiency analysis, so we need to understand how that works. And it's coming back to us through the physician value-based modifier, but they're all based on ICD-9 codes now and ICD-10 codes very soon. So how does the information get from our medical records into the system? From office-based practices, it goes through the physician quality reporting system, and for hospitalized patients, it comes from the claims data. These are billing records. This is where all of this analysis originates. They're not looking at your charts. They're not talking to your patients, all of whom love you, I'm sure. They're getting this off the billing records. So the principal diagnosis and all the secondary diagnoses get listed here, and it's the accumulated total of those that reflects the severity, complexity of the patient's care. So when we see people and don't list those secondary diagnoses, like the orthopedist, they don't write down anything. We're not getting credit for the patient's entire complexity of care. So we need to pay increased attention to that. So in addition, they'll have the length of hospital stay, how much was spent taking care of them, and so this is the information they use to extract quality and cost efficiency information. This is a screenshot taken from Medicare.gov, and right now this is just a directory, name, address, office phone number, but soon this quality and cost efficiency data is going to be published for the public to see at the Medicare website. Now, using this same information, there's a much more detailed confidential report that you can have access to, and there's an appendix in the back of the handout that explains how you can get your own QRUR report, quality resource and use report. And they're going to be grading each of us as either high, average, or low for both cost and quality. Now, they're implementing these adjustments in reimbursement in a graduated fashion. It's already affecting this year, starting January of this year, for mega groups, the groups that have more than 100 members that bill under the same tax ID number. But by the year 2017, it will involve all of us. And by then, if you're deemed to be high quality and low cost, they will boost your reimbursement by 4%. If deemed to be low quality and high cost, this group is going to get their extra 4% because they're going to take it away from this group. And these are the diagnoses that they're analyzing to get these determinations. Emphysema, coronary artery disease, heart failure, and diabetes. Now, as soon as we say that, the physician quality reporting system, the information in, the value-based purchasing modifier, the adjustment of reimbursements back, and the meaningful use of electronic health records as separate programs are going away, but they're not disappearing. They're being consolidated into what's called the Merit-Based Incentive Payment System, or MIPS. You're going to be hearing a lot about MIPS. And each of us is going to be graded with scores between 0 and 100 in each of these 4 categories: quality of care, meaningful use of electronic records, use of healthcare resources, which is cost efficiency, how much testing we do to accomplish their care, and activities undertaken to improve clinical practice. So when 2017 ends and 2018 begins, we'll have the negative 4% stick, the positive 4% carrot. But by the year 2021, which sounds like forever from now, but it's only 6 years away, they can boost our payments by, the law says, not more than 10%, but they can also take 9% away. So the stakes are increasing. So just a little bit more about background information, risk adjustment. That's why a life insurance policy for a 16-year-old costs less than a 60-year-old that smokes 3 packs a day. So they take those sort of factors into consideration with adjusting risk. And so we're interested in risk-adjusted outcomes. And you determine that by looking at observed outcomes and comparing it to what's expected. And you can observe anything: mortality, length of stay, medicine use, imaging use, post-op infections, readmission rates. So we look at what's observed, compare that to what's expected for that population, and we get risk-adjusted outcomes. Then when we compare that with how much money we spent to get there, you get a concept of cost efficiency. So that's the outline of how they're doing this to assess us. Now, the observed outcomes are easy enough to identify. That's what's on the chart. But where do they get this group to compare my care to? Well, these are other physicians' patients with similar characteristics: demographic, age, sex, and principal diagnosis, secondary diagnoses, and procedures that are deemed to affect whatever metric you're looking at. Again, it's observed versus expected. So if the height of this bracket represents my patient's true, total, complete severity and complexity of illness, but the height of this bracket represents, by virtue of how I document, how the coders can code and thus report to the world how sick my patient is, then this gap between here and here is a problem. And it's this documentation gap, this difference between my patient's true severity of illness and how it's represented, and it's based entirely on the documented language I use in the medical record and the ability of the coder to translate in that into the administrative languages of ICD-9 and ICD-10. So this pool of other patients to whom my care is compared depends not on how sick my patient is, but how sick my patient looks on paper to the coder. And that's based on what I write in my emergency medicine note, what you write in the H&P, progress note, op notes, and most importantly, the discharge summary, because that's the attending of record's last statement on how the patient presented, what conditions we identified, how we intervened, how they responded, and how we expect the post-hospital phase to go. So by closing this gap, we'll reduce downcoding, we'll reduce denials of payment based on an inadequate representation of the medical necessity for the services that we provide. And again, medical necessity is determined by the insurance payer, not by us doctors. And we want our quality portrayals to be accurate. We want our cost efficiency portrayals to be accurate. And by closing this gap, we'll be a long way down the line toward getting the increased specificity required for ICD-10. A little bit more in the way of background. The principal diagnosis for the coding system is that condition established after study, may not be apparent on the front end, but that condition established after study to be chiefly responsible for occasioning the patient's inpatient admission to the hospital. So, for example, it may not just be the fact that they have pneumonia. We treat pneumonia as an outpatient all the time. It may be the fact that they have sepsis or they have acute respiratory failure that makes this pneumonia have to be in the hospital and not treated as an outpatient. Secondary diagnoses, also called comorbidities, anything that meets any one of these criteria, something that requires clinical evaluation, therapeutic treatment, diagnostic procedures, anything that extends the length of the hospital stay or requires increased nursing care or monitoring qualifies as a secondary diagnosis. And then you add procedures on top of that. And it's these three elements that come together to make the DRG, the diagnostic related group, that determines how much the hospital gets reimbursed. We as physicians used to not care so much about that because that was just for the hospital. But these are the same elements now that go into determining our quality of care and our cost efficiency analysis. So now we care. It's no longer a me, it's a we. We're all in this together. So let's talk a little bit about these languages and their translation. You know, there's a certain language that we use with each other and on the medical record, and then there's this administrative language that takes our language and turns it into codes which are used for billing and all of these statistical assessments, and there's no Rosetta Stone for this. It's not a smooth translation in many instances. These are the three, there are others, but these are the three most important administrative bureaucratic languages that our medical language is translated into. The first two are for inpatients only, and the HCCs are for outpatients as well as inpatient codes. The MSDRGs, obviously Medicare severity diagnostic related groups, Medicare and most of the private insurance payers use this methodology. The APR-DRGs, all patient refined DRGs, is used by Medi-Cal and most states, not all, but most states' Medicaid programs. The HCCs, the hierarchical condition categories, accumulate the ICD-10 codes and soon the I-10 codes, not only from inpatient diagnoses, but outpatient diagnoses as well. And these are all the languages used for processing after these numbers leave the hospital. But they're all designed to communicate the patient's severity of illness. So let's look a little closer at the MSDRGs. They revolve around a term we call a CC. 1C stands for comorbidities, the secondary diagnoses, everything that the patient brings with them to the hospital that we identify before the inpatient order is written. Their hypertension, their diabetes, their lupus, and also the new things that arise, their pneumonias, their heart attacks, strokes, fractures, anything that we identify before the inpatient order is written is classified as a comorbidity. The other C stands for complications, and it's those things that arise anew after the inpatient order is written. So the two C's are comorbidities and complications. An MCC is just a major one of those. So the three-tiered system of the MSDRG, identification of severity of the secondary diagnoses, is the highest level of credit is the MCC, the middle level is a CC, and then the third tier is neither one of those, and we get no increased relative weight for those terms, and that's important as we'll see in just a moment. The APR-DRG system has two categories, one called severity of illness, one called risk of mortality, and they're each assigned a single digit between 1, not sick, and 4, very, very sick. And the two numbers don't have to be the same. You can have a high severity of illness with low risk of mortality, so the numbers can be different. And the HCCs identify the patient's severity of illness of conditions that are the secondary diagnoses. And I say secondary diagnoses because the principal diagnosis is what it is. It's these accumulated secondary diagnoses that add relative weight that accrue to our quality of care and cost efficiency determinants. In the HCC system, every secondary diagnosis has a fraction of a number, and they all add up together to a total sum that identifies the patient's total severity of illness, complexity of illness. And these are also called outpatient DRGs, which we'll see in just a moment. Now, going to the MSDRG system, the three tiers of severity, no increased relative weight when it's not a CC or an MCC, modest increased weight with a CC, and major increased weight which accrues to our credit with these diagnoses. And I picked these two terms specifically because in my more than quarter century practice of emergency medicine, these were two of my favorite terms. I used them all the time. I had no idea I was getting absolutely no credit when I used them, none. But after it's been explained to me, and I'm humbly come to understand, it seems to make increasing sense to some point. A mental status is like a nose. Everybody's got one. Altered nose is not a diagnosis. Neither is altered mental status. It gives you no clue as to what is causing the alteration. But if we name it something like a delirium, we get increased credit for that. If somebody has an altered mental status because their sodium's 110, they're delirious, so we call them delirium, because of a metabolic encephalopathy, we get huge credit for that term. So we go from no credit to huge credit. Same patient, same doctor, same nurses, same hospital beds, same length of stay. But when we use the correct term, when we know the terms that we get credit for, we're better off. Unresponsive is your daughter when she's mad at you. If you call home and you hear our daughter is unresponsive, you're going to be saying, well, what's she mad about today? But if you call home and you hear she's unconscious or in a coma, that just feels different, okay? We get no credit for unresponsive. We get big credit for unconscious or coma. Heart failure. When I was in residency and somebody had an exacerbation of heart failure, the diagnosis was CHF. Everybody understood they had heart failure. It got worse. They needed to be in the hospital. The coding system now makes no such assumptions. It makes no assumptions at all. We have to tell them what's going on. Because they had heart failure last week, they weren't in the hospital. Well, they have an acute exacerbation of heart failure. Plus, they want to know if it's systolic, diastolic, or combined. Now, these are not even the current terms in the cardiac literature. They're like heart failure with reduced ejection fraction. And that's fine. They can use that. They can use terms like the New York Heart Association classification, Killip classification, but they all code out to this. No credit. So they have to use this term, and we talked to the cardiologist just yesterday, and I'm hearing they're documenting better even as we speak. So God bless them. So we want to know what we need to code, what we need to write to get credit for it. Symptoms we don't get credit for. We add functionality, and most important, acuity, we get increased relative weight. More about the HCCs, inpatient and outpatient ICD-9 codes, ICD-10 codes. A normal, average, healthy person will have a total risk-adjusted factor of about 1. Somebody with a lot of illnesses, they add up, so the number will be higher. These are extremely important to us because this is the methodology, the HCC methodology, that Medicare uses to adjust our reimbursements through the value-based purchasing modifier and in a few years MIPS. This is the methodology that CMS uses to determine the Medicare cost per beneficiary. And this is also the methodology they use to fund accountable care organizations, Medicare Advantage plans, and independent practice associations. So we need to understand how this works and some of the nuances through which we give ourselves credit. Now, this is an HCC methodology table. It looks pretty heavy, but this is all about one patient who is a 65-year-old female who has a lot of things going on in her life. She has breast cancer that's metastasized. She's malnourished and has pressure ulcers. But you'll notice that it's based on calendar year codes. That's because the HCC codes all expire at the end of the calendar year. The reason for that is to encourage somebody, some physician, to see them every calendar year to reaccumulate these codes. If you don't, all you get to fund their Medicare Advantage program, for example, would be that which is related to their base demographic. So this has a relative weight of 0.3, and so we multiply that by the reimbursement base factor, which is about $10,000. So we'll have $3,000 to care for her next year. But let's look at all her comorbidities. Cancer of the breast has a relative weight 3 times higher than her baseline. That it metastasizes to bone doubles that relative weight yet again. She's been sick, she's gotten malnourished, there's increased relative weight for that. Stage 3 pressure ulcer relative weight, stage 4 is much more heavily weighted. So when we document each of her comorbidities, we've got almost $60,000 to care for her next year. So when she gets admitted to Pomona Valley Hospital and we're dipping our ladle into the bucket for reimbursement, which bucket you want to be dipping into? I want to be dipping into this deep one over here. So that's why these are very important. You'll notice that history of breast cancer has a relative weight of goose egg. We get no credit for that. Why is that? Well, the coding system highlights the ambiguity with the term history of that we were taught when we were medical students, and we've taught medical students behind us. I have a history of strep throat, but I don't have strep throat today, and I have no sequelae of strep throat. But when we say somebody has a history of emphysema, diabetes, hypertension, we're communicating they still have that. Well, that's another one of those assumptions that the coding system does not make. When they see the phrase history of, we're telling them, yes, they had that, but they don't have it now, and we're not doing anything to treat it at all. So with breast cancer in particular, if somebody has a lumpectomy, local radiation, they're on tamoxifen for 5 or 10 years, even though tamoxifen is not anti-neoplastic, as long as we're actively treating the disease, we get the increased relative weight for that. But once we're stopping all therapy, something like breast cancer, we don't want to forget that because that can rear its ugly head, down the line. We want to leave it on the problem list, but we're not expending any resources to care for it, so we're not getting any resources back, but yet it stays on the problem list. Now, I would caution you with some electronic health records, there's, you pull down scrolls, you get history of, click, history of, click, history of, click. You may think you're populating the problem list with conditions the patient has, but when you use history of, you're telling the system they don't have this, they don't have that, they don't have this other thing. So caution in using history up. I've been doing this for 2 years now, and I still, history of will sneak out of my mouth every now and then when I mean that it's that they actually have it. So it's habits, die hard. Now, there are about 70,000 ICD-10 codes. There are only about 70 HCC codes. There's not an HCC code for everything. They funnel down very narrow. They emphasize things that are active and busy and require resources. So if something is chronic and indolent, for example, atherosclerotic heart disease without angina, you can have that for years and no big whoop. But if you have any form of angina, any manifestation of angina, there is an HCC code for that. So this little nuance, if somebody's on chronic nitrates, Imdur, Nitrodur, Nitro Paste, one of the reasons that they would be on that is if they have frequent recurring angina and they're using a lot of sublingual nitro, we'll put them on a long-acting nitro to reduce their breakthrough angina. So as long as we're treating that condition, we need to note that condition so we can get credit for it. Now, it's a little subtle with that example. There are some examples that are obvious. If I have diabetes and I'm taking glyburide and my blood sugar's normal, my A1C's normal, do I still have diabetes? Yeah, of course I do. Same thing with hypertension. Even though my blood pressure is normal, my LV function and size is normal, I still have hypertension. Same thing with seizure disorders. Not so obvious if somebody has angina and we put them on a long-acting nitro and their angina goes away. They're not symptomatic of it, but as long as we're treating with that medication for that condition, we need to note the condition. Another one that can be subtle, atrial fibrillation. If somebody comes in atrial fibrillation and we put them on amiodarone, they may convert back to normal sinus rhythm, but we may continue the amiodarone for 3, 4, 6 months. Even though they're in normal sinus rhythm, the reason they're on that medicine is because of atrial fibrillation, so we can still diagnose the atrial fibrillation because that's what we're treating, that's the condition we're treating with that medication. And also with AIDS and antiretrovirals. AIDS is just another chronic disease now. Nobody dies of AIDS anymore unless they just stop taking their medicine. But if they've ever had an AIDS-defining illness, if they've ever had an AIDS-defining CD4 count, then they have AIDS for purposes of diagnosis and coding for the rest of their lives. Because they're taking the medication, that's what we're treating with the medication. They may be normal, healthy, normal weight, active. They need to be careful crossing the street because they're going to die of something else other than AIDS. We don't want them to get hit by a bus. But that's one of those idiosyncrasies of the coding system. Pneumonia, simple pneumonia versus complex pneumonias. The coding system calls what we call complex pneumonias respiratory infections and inflammations. Notice that the relative weight for these is 60% higher than the simple pneumonias. The simple pneumonias being community-acquired, viral pneumonias, and the like. So let's pay attention to what is in the more complicated category. Gram-negatives, Legionella, staph, whether it's methicillin resistant or sensitive, TB, fungi, aspiration pneumonia, probably the most common one of these that I've seen in my practice, empyema, abscesses, and mediastinitis. Now, interestingly, the coding system codes pneumonias based on the organism causing the pneumonia, not the location of the pneumonia, like right lower lobe. We hardly ever know with certainty what organism it is causing the pneumonia. So how do we deal with that? Well, we're telling the world what we think is the target organism by the antibiotics that we select. If we think it's community-acquired pneumococcus, we'll put them on levaquin, Rocephin, and Zithromax to cover the atypicals. But if we think somebody may have aspirated and we want to cover for the anaerobic oral flora, then we'll use something like Unison to cover that. Or if they've been on steroids forever and we are concerned they may have Pseudomonas, then we'll select a different antibiotic for that. And we can use this information diagnostically to help give us credit, even though we may not be certain what the actual diagnosis is. Uncertain diagnoses can be coded by the coders as if they are established in fact if we document that qualification at the time of discharge. So we can use terms like likely, probable, suspected, still to be ruled out at the time of discharge, and the coders can code that as if it were established in fact, as long as they're in inpatient status. Doesn't help me in the ER, doesn't help you in the office, doesn't help when somebody's in the hospital but in observation status. But if they're in inpatient status, we can use this qualified diagnosis. and get credit for it. It has to be clinically reasonable, and it has to appear either in the discharge summary on the discharge note or the last progress note or the discharge order. So when you're making your diagnoses, on the discharge summary, if you say probable aspiration pneumonia or likely aspiration pneumonia, then they can code that as a higher weighted pneumonia. And this is an example of what's going to kill small rural hospitals. I don't know if the name Ezekiel Emanuel means anything to anybody. He's a physician, very prominent in the development of the Affordable Care Act. He's the brother of Rahm Emanuel, the mayor of Chicago. He says they expect 20% of hospitals to close. No, I don't think that's really a very good idea. But this is how that's going to happen. They're going to see patients with pneumonia that are actually having complex pneumonia or sepsis or acute respiratory failure. They're going to be sick people, and they're going to code out as simple pneumonias. So they're spending this much to take care of them. They're getting this much back, and no margin, no mission. Those hospitals are going to go out of business because they're not getting enough resources to pay for the care they're providing. And so, and not every hospital has the resources to bring in somebody to have this that Pomona Valley is doing for you. So these are the 7 DRG options for pneumonia. These 3 simple pneumonia, these 3 complex pneumonias, and this category in green, no secondary diagnosis credit added at all, a CC, that mid-level of increased relative weight credit, and then the MCC that's very higher. Well, let's look at just the simple versus complex with no secondary diagnosis to get in the way, and look at the relative weights. Relative weight 0.7 versus 0.9 and change. So when we identify a complex pneumonia, that accrues to our accumulation of relative weights for our quality of care analysis, cost efficiency analysis. But look what also happens. The expected length of stay goes up from 2.9 to 3.7. So if I have this patient in the hospital for 3 days and it codes out as a simple pneumonia, I don't look great because I've extended beyond their expected length of stay. Not by much, but a little bit. Same patient, same doctor, same nurses, same drugs, same length of hospital stay. If it codes out as a complex pneumonia and I send them home in 3 days, I look great. And that's how they're making these quality and cost efficiency determinations. They're just using the numbers. And this is how we can influence the numbers. Now, what if they're septic? Wow, look what happens to the relative weight there. Expected length of stay. And of course the reimbursement goes up, and until we get to bundled payments when we're all dipping out of the same bucket, this helps the hospital, but this helps get respiratory therapists at night and on the weekends and that sort of thing. So what are the criteria for diagnosing sepsis? Well, this is from the literature, 2012 Surviving Sepsis Campaign. Has to be an infection that's either documented or suspected. And some of the following, which it sounds like Monty Python wrote the subtitle. And so we interpret some as meaning at least 2 of these. Temperature too high or too low, heart rate too high, tachypnea, altered mental status, which we already know is not enough to say by itself. In this setting, altered mental status would be encephalopathy due to sepsis. Encephalopathy is one of those secondary diagnoses at the very highest MCC level. Fluid shifts, hyperglycemia over 140 in the absence of diabetes, white count too high, more than 12, white count too low, less than 4,000, left shift greater than 10, elevated CRP, procalcitonin. But you notice the positive blood culture is not on this list. You don't have to have a positive blood culture to diagnose sepsis, not required. Now, the things that we use to meet the criteria for sepsis need to be things that aren't easily explained alternatively. For example, if I see a patient with a temperature of 102 and a heart rate of 95, and I give them 2 Tylenol and a liter of fluid, and now their heart rate's 72, okay, maybe that wasn't septic. Maybe that wasn't sepsis. It has to pass the smell test. These have to be sick folks. And likewise, if their white count's 35,000 because they have leukemia, we can't use that in the criteria for sepsis. Severe sepsis is defined as sepsis with acute organ dysfunction. Lung, kidney, manifested by oliguria or increased creatinine, coag abnormalities, and ileus is a dysfunction of the GI system, thrombocytopenia, increased bilirubin, tissue perfusion variables of delayed capillary refill, modeling, and then septic shock. Shock is a diagnosis of tissue hypoperfusion, not of blood pressure. So they don't have to be hypotensive, but if they are hypotensive refractory to fluid resuscitation, that meets the criteria. But if their blood pressure hasn't dropped yet, but their lactate level is greater than 4, that supports the diagnosis of compensated septic shock, and we can use that. The term urosepsis has to go away. Do we need to mourn its loss? There's no code for urosepsis in ICD-10. In ICD-9, it codes to just a simple urinary tract infection. But in ICD-10, it goes away. So we have to use the term sepsis due to pyelonephritis or a urinary tract source, have to use sepsis. Now, SIRS, the Systemic Inflammatory Response Syndrome. In ICD-9, it can either be caused by an infection or something that's not an infection. In ICD-10, SIRS is only non-infectious sources. Severe pancreatitis, tumor lysis syndrome, severe trauma, severe burns. If we think somebody is having an inflammatory response due to an infection, we go back old school, we just call it sepsis. Not SIRS due to infection, but sepsis. So here's an example of the value of just heart failure as a secondary diagnosis. So we're using a patient with simple pneumonia, no secondary diagnosis of any credit, relative weight 0.7. So let's say the patient has heart failure, not history of heart failure, they have heart failure, but it's not decompensated, it's not an acute exacerbation. But the fact that they have it makes us more conscious of fluid resuscitation. We don't want to overload them. We don't want to tip them into heart failure. So the system gives us credit for that intellectual energy we have to expend, but we have to tell them what's going on. So when we identify the patient as having systolic heart failure or diastolic heart failure, that adds a secondary diagnosis with increased relative weight. Another secondary diagnosis at the middle level is chronic respiratory failure. When your patient, comes in towing their oxygen canister on the little two-wheel dolly attached to their binasal cannula, for Medicare to pay for home oxygen, there has to be a blood gas analysis out there somewhere that documents hypoxemia on room air. So I don't need to know when that blood gas analysis was drawn. I don't need to know what the number was. I can say chronic respiratory failure based on remote blood gas analysis, and that locks in that secondary diagnosis and makes it review, audit, contractor proof. The RAC auditors, they make their living looking for diagnoses in a hospital record that they can take away as unsubstantiated. So when we declare a diagnosis, we want to be sure that nobody's going to take it away from us down the line. So CHF is a secondary diagnosis, acute chronic versus acute on chronic. If we note the functionality, like systolic, we get partial credit for that. Chronic heart failure, we get partial credit for that. But any acute exacerbation, whether just acute or acute on chronic, and we note the functionality, huge relative weight for that. When we go old school on heart failure and just call it CHF, nada. We get no credit for it. So for heart failure, it's got to be acute, chronic, acute on chronic. The functionality, systolic, diastolic are combined. Now you can use the New York Heart Association classification. You can use terms, heart failure with preserved ejection fraction for what we call diastolic heart failure. But they all code to heart failure not otherwise specified, and there's no credit for that. So we're being asked to describe a few more of the trees to justify calling it a forest. So my partner, Dr. Kennedy, who's been doing this many, many more years than I, and he's a genius, he created this mnemonic. We're from Nashville, so it's easy for us to remember. It's music. The M stands for manifestations, those presenting signs, symptoms, syndromes. It's the first thing we see, the first thing we hear. The underlying cause is U. S makes us think about severity or specificity. I, the instigating or precipitating cause. C, consequences or complications. So when we identify a condition and plug it into the mnemonic and think about the other components, anytime we can link condition and cause, condition and consequence, the relative weight goes up very frequently. So here's just the most simple manifestation of that. Manifestation of heart failure, underlying cause, cardiomyopathy, effusion, pulmonary hypertension, severity, specificity. We declare whether it's systolic or diastolic and whether it's an acute exacerbation or not. Instigating or precipitating factor. Well, maybe their paroxysmal atrial fibrillation with a rapid ventricular response has pushed them over into heart failure, MI, endocarditis. Consequences or complications, do they meet the criteria for acute respiratory failure, acute kidney injury, cardiogenic shock? And it may help us pull in some more of the details. Now, we talked about how the review audit contractors like to take diagnoses away. So Dr. Kennedy created this rule of 3 just to establish clinical validity. I could write in a progress note today the term sepsis, and the coders could legitimately code sepsis, even if that's the only place in the chart it's identified. But the review audit contractor is going to come and say, well, you didn't really think the patient had sepsis because you never said it again, so we're going to take that diagnosis away from you. So we like things to be mentioned at least 3 times, in the H&P, progress note, and on discharge summary. Now, as Dr. Kennedy and I are competitively OCD, I thought it'd be fun to have 3 rules of 3, so I made up 2 more. The second rule of 3, parts of speech. For every condition, the condition itself is the noun, an adjective to describe it, if it's acute, chronic, acute on chronic, linking it, caused by, due to, resulting in, and then during the course of hospitalization, its progress. Is it better, worse, the same, or resolved? And then the third rule of 3 is once on the problem list, always on the problem list. Things get better. Sepsis gets better. Acute respiratory failure gets better. Status asthmaticus gets better. We don't want to forget those when it's time to do the discharge summary. I've reviewed a lot of charts. Every hospital I go to, they show me a chart where the patient was admitted with pneumonia, got treated for pneumonia, got better from their pneumonia, and on the discharge summary, the word pneumonia appears in no place. It happens. They get better, we're thinking about other things. So we want to cite as new any condition that begins after the inpatient order is written, but when we do identify that, we want to ask the question, could this have been present on admission? And if it turns out, say somebody gets admitted for evaluation of a syncopal episode, and it's not until hospital day 2 that we do the CT angio of the chest and determine there was a big PE in there, well, that explains the syncopal episode. But if they had the PE during the course of the hospitalization, we get dinged for that and we don't get credit for that. So we need to note that that was present on admission, so we don't get dinged. Now, the coders may catch that and query you, but we don't want that to get slipped. And things improve with intervention, so we don't want to forget them. That's why we want to keep them on the problem list. So I'm going to ask you to stretch your imagination now. This is the structure of the ICD-10 coding system. It's a 5-digit code. Picture a 5-lane Southern California freeway just totally clogged and full. No more room. This is a ICD-10 code structure. It's a 7-digit code, and many of these can either be numbers or letters, which makes a possibility of 34 different options in each one of those. So picture a highway with 34 stacked decks. Lots more room for traffic. So lots more room for expansion. Important concepts, we talked about acuity, anatomic specificity, lateralization, episodes of care, combination codes, and the present on admission identifiers. We talked about heart failure, acute, chronic, acute on chronic. And this is to identify the fact that just by throwing the word acute in front of anything, we don't always get extra credit for it. Acute bronchitis is just not that resource intensive, so we don't get any increased relative weight for acute bronchitis. Neoplasms, the term mass, we get no credit for. Tumor and neoplasm we get credit for, but not mass. Left, right, overlapping sites, but if we don't add the anatomic detail, we get no credit for it. So the more anatomic detail you can identify, the better. The episodes of care we talked about, this is to remind me with an office practice when you're billing CPT codes, there's a CPT code for the initial encounter that's your relationship with the patient or your office practice's relationship with the patient. That's not what these codes are for. These codes are based on the patient's phase of healing, not the physician encounter. So you don't have to worry about these ICD-10 codes in the office practice. So how does the CDI team function to help us? Well, when we write illegibly, or we're not really clear in what we say, or we're not consistent, we mention something just once and don't repeat it, or we lack the precision they need to give us credit for what we actually do, or if a neurologist says TIA and hospitalist says stroke, those conflicting statements need to be ironed out. So what clinical documentation is not, and we use the word integrity here, clinical documentation, it's not about upcoding. Upcoding is ascribing to a patient a condition they do not have. That's not what we're about at all. That's fraud. We don't do that. But we want to be accurate. We want to understand the rules of the game as written largely by non-physicians to give us credit for the work that we actually do. So you're the rock stars, and these are your backup singers. You're the ones the population is clamoring to see, but these people sure can make your record better. It's another Nashville illusion. Now, some coding rules. Coders can code only from licensed professionals, physicians, nurse practitioners, PAs, with a face-to-face contact with the patient. So they can't code from EKG reports, they can't code from laboratory reports, they can't code from X-ray or path reports, with the exception that when the physician notes a finding on X-ray that documents their acknowledgement of the intracerebral hemorrhage or a fracture, the coders can go to that image report and extract additional detail about the location of the fracture, the characteristics of the fracture, or the specific location of the intracerebral hemorrhage. But the attending physician has to acknowledge that diagnosis on the record. They can't code from arrow down NA 115. They can't code hyponatremia if you don't use the word hyponatremia. And one of the problems is if you get a query about that, they're not allowed to lead you. They can't say, you wrote arrow down sodium 115, did you mean hyponatremia? You didn't use the term hyponatremia, neither can they. So they'll ask you, what's the clinical significance of this? And so it sounds like the query is coming out of left field, tangential, indirect. It's not because they don't know what they're doing, or they don't know what you're doing, or think you're doing something wrong. They're not allowed to lead. So that's why some of the queries can seem somewhat indirect. This is a general equivalence mapping table. You will have a copy of this. It has every ICD-9 code, every ICD-10 code, and whether they're an exact match or an approximate match. Do not print this table. It's 2,000 pages long. You'll run out of yellow ink. Now, this is to highlight the fact that in ICD-9 we have codes for malignant hypertension, benign hypertension. In ICD-10, there's one code for hypertension. Benign hypertension and malignant hypertension code to the same code. So we've lost that specificity. I don't know why they did that. So we have to look for in-organ injury due to hypertension. Hypertensive encephalopathy, hypertensive kidney disease, hypertensive heart disease. If you have somebody with a history of hypertension and heart failure that's not due to an MI or something, if it's hypertensive heart disease, then we have to link the hypertension and the heart disease, cardiomyopathy due to hypertension, or hypertensive cardiomyopathy, to get that increased relative weight. For some reason, the coding system does not automatically link the two H's, the heart and hypertension, but hypertension and kidney disease, they are automatically linked. There are a lot of idiosyncratic rules that I can't explain. That's just the way that is. This is another table that we have for you. Every ICD-10 code, its description, and whether it has an HCC code or not, and if it does, what its relative weight is for patients in the community versus patients institutionalized, like nursing home patients. Sometimes they're different. Every MSDRG secondary diagnosis, whether it's a CC, MCC, not depicted here, or neither, and in the APR Medi-Cal system, it's severity of weight number, risk of mortality number. Now, here you see HAC. If the term HAC appeared here, then if this patient acquired this condition after the inpatient order was written during the hospitalization, we would not get this increased relative weight ascribed to us to reflect our quality of care. The hospital would not get this relative weight assigned to add to its DRG payment. We all have to eat that. So we don't like hospital-acquired conditions. And this is the Agency for Healthcare Research and Quality Patient Safety Indicator for surgical complications. Requirement for laterality, left, right, and we're concerned that if the payers know, we know if it was left or right, or should know if it was left or right, and we didn't document that and didn't submit that code, that having an unspecified laterality for a condition when we know if it was left or right but just didn't tell them, that'll give them an excuse not to pay the claim. Now, Medicare has declared that they're going to give us a year of forgiveness. Thank you, Medicare. I'm not sure if the privates are going to be so forgiving. So just, there's nothing more simple than adding left and right, so we want to be sure that we do that. This is just a blow-up of the billing record that indicates that they have to note present on admission for everything. If you get queried whether something was present on admission, if we answer yes, it was present, then we're not subject to penalty. If we answer no, it happened after the patient was admitted, we may be subject to a penalty. It's not an automatic thing. Everything is risk adjusted. And when you hear risk adjusted, think graded on a curve. So we're being compared to other hospitals and their rates of readmission for this same condition. If we answer that, well, we just don't know if it was present on admission or not, then that gets coded as if a no and we're subject to the penalty. But if we say it can't be clinically determined, then they give us the benefit of the doubt. I think if we just say we don't know, they think we're blowing us off, so they add that to the subject that we might be penalized for. Now, this is the list of hospital-acquired conditions: pressure ulcers, stage 3 and 4. Stage 3 involves necrosis of muscle, 4 necrosis of bone. But if they have a stage 1 pressure ulcer on admission, which is just red skin that does not blanch with pressure, then if it deteriorates during the course of hospitalization, we don't get dinged for that because it was present on admission. Even though it wasn't an ulcer, it was still a stage 1 pressure ulcer, so we don't get dinged for that. So when we do our skin examination and we write W and L, it needs to be within normal limit, not we never looked. Infections from catheters, whether urinary tract infections or IV infections, for some reason for diabetics, they think that if they did not come in DKA, they should not have DKA during the course of the hospitalization. It's not an unreasonable list. Bundled payments. They have recognized for some years now that the fee-for-service rewards quantity of care rather than quality of care. So they're trying to change incentives toward how much we're spending and attention to quality and that sort of thing by the bundled payment environment. Now, in the current unbundled environment, everybody sends a bill, everybody gets a check. In the bundled payment system, Medicare sends one check, and it goes either to the hospital or to an accountable care organization, and that pie is divided up according to pre-negotiated contracts. What we want is for the size of that pie to be the appropriate size. And that's based on the principal diagnosis and all the accumulated secondary diagnoses. That has to do with making the pie the appropriate size. And not only does the bundle cover the interim of hospitalization, it also covers the first 30 days after discharge. So if the patient has to come back to the emergency department, if they have to be readmitted, there's no more money for that. It comes out of the original bundle. So we might be willing to pay a little more for home health nursing to make sure they take their medication, they're up in ambulatory, to keep them from having to be in the hospital. Now, this is coming to the orthopedists. They've announced that starting January 1 for knee replacements, hip replacements, they're going to be reimbursing orthopedists under the bundle payment system. So the hospital's reimbursement, the orthopedist's reimbursement, it's all going to come out of the same bucket. These concepts are not new. There have been pilot programs for bundle payments for the last 3 or 4 years, and several hospitals are doing quite well under it because it's broken down silos of communication between the primary care physician and the hospitalist and the preoperative people, the anesthesiologist, the laboratory, the imaging, discharge coordination. Everybody's working together more efficient, and it's actually working very well. In ICD-10, acute respiratory failure can either be hypercapnic or hypoxemic, and for acute respiratory failure, it needs to be, a fairly life-threatening scenario. With chronic respiratory failure, it can be hypoxic or hypercapnic as well. For acute hypoxemic respiratory failure, PO2 less than 60, but since we've had pulse oximetry, my blood gas drawing has dropped 98% probably. So you need a consistent level below 88% because we're all familiar with the oxygen hemoglobin dissociation curve. It really drops off precipitously after that. So not just a spot reading below that level, but if it's consistently below that, and it's not based only on the number, but with respiratory assistance or monitoring. If we have to intubate and mechanically ventilate, okay, that's pretty obvious. But we can use BiPAP to do non-invasive ventilatory support. But high flow oxygen, or even if you're just hovering over the patient trying to figure out what else can I do to keep from having to intubate this end-stage COPD, because once you put them on a vent, you're not ever going to get them off a vent. That can qualify as acute respiratory failure as well. One of the most frequent settings in the emergency department is somebody in acute systolic heart failure comes in, pulmonary edema, diaphoretic, hypertensive, volume overloaded, and we'll put high flow oxygen on, get a bunch of nitrates going sublingually to begin with, then IV, diurese them, and by the time the hospitalist comes to write the inpatient order, their blood pressure is normal, they're vasodilated, they got more room for the fluid to go, they may have diuresed a liter, they may no longer be in acute respiratory failure, but they were, and we want to preserve that diagnosis for admission and for the discharge summary, because this is like a quarterback throwing a touchdown pass. The quarterback and the receiver both get credit for the touchdown. It's a we, not a me, so we don't want to lose these diagnoses. Hypercapnic respiratory failure, PCO2 greater than 50. Coding clinic, our Supreme Court says if it's over 50. And the pH will vary depending upon how long it took them to get there. This just highlights the relative weight differential. Simple pneumonia is a little lower weighted in general than COPD, but respiratory failure is most highly weighted. Some terms that we get no credit for: oxygen dependency. I'm oxygen dependent. Anybody else? Yeah, we get no credit for that. Asthma severities, just baseline descriptor. It's either intermittent or persistent, and if persistent, mild, moderate, or severe. And this table is in there. It tells you exactly how to classify these. In ICD-9, pretty easy to code. In ICD-10, we've got their baseline, intermittent, mild persistent, moderate persistent, or severe persistent. But yet within each of those, it could either be uncomplicated, which means they're in the hospital for something else, or exacerbation, or status asthmaticus. Anybody that comes to inpatient status because of their asthma is in status asthmaticus. They just have to be, because most of the time we treat them and treat them. Most of the time we treat them and treat them with the same drugs they've got at the house. We just give them more of it. But if they have to be admitted, most of the time it's to observation status, because they just need a day or two. But if they get to inpatient status because of an asthma exacerbation, that's got to be status asthmaticus. Got to be. COPD, if they have an acute lower respiratory tract infection, even though their COPD doesn't seem to be exacerbated, if they just have that and they're admitted, then that's a secondary diagnosis at the level of a CC. If they don't have an infection, but they have an acute exacerbation of their COPD, then that's a secondary diagnosis at the level of a CC. Now, lots of codes for smoking, environmental exposure, if they used to smoke but they quit, occupational exposure, so your bartenders, tobacco dependence and tobacco use. Now, there's increased relative weight if they have symptomatic withdrawal. And this applies not just to nicotine, but to almost every other substance, methamphetamine, cocaine, opioids. If they have symptoms of withdrawal, that is a secondary diagnosis at the level of CC. So if you're sending somebody home on Chantix, or they come in, chewing Nicoderm, or you're standing in the hallway arguing with them because they want to go outside and smoke, those are symptoms of withdrawal, and we get extra credit when we diagnose that. Third universal definition of MIs has to be a setting of ischemia with the rise and fall in a cardiac biomarker, now typically troponin, and new EKG changes or loss of myocardium via imaging, echo, or MUGA, or identification on cath of a thrombus. Now, in ICD-10, obviously there are codes for an acute MI, and for purposes of coding, they call it an acute MI for the time from when it occurs to the next 4 weeks. So if they go home and they come back 2 weeks later, it still gets coded as an acute MI. If they have a second MI, whether it's the same anatomic location, same vessel, or a different one, if they have a second MI within that 4-week period, then that one is called a subsequent MI, and they still code the acute MI. So we get credit for both of them. Now, an old MI, older than 4 weeks previous, there's no increased relative weight assigned to that. So if somebody has had a previous MI, it's important to know when that was for purposes of coding and accreditation. Now, ICD-10 classifies MIs as either ST elevation or not, by anatomic region, anterior, posterior, inferior, or by vascular anatomy. But the literature defines MIs with these number types, spontaneous being the most common: plaque ruptures, platelets activate, platelets clot, blood flow stops, heart muscle dies. Type 2, to me, are the most entertaining and interesting because these are MIs based on an ischemic imbalance. The heart demand for oxygen is not met by the blood supply, so you get heart muscle injury due to that. Type 3 is when there's sudden death. Somebody may have had EKG changes or been symptomatic but dies typically of a dysrhythmia before biomarkers can elevate. Type 4 is related to cath, 4A to cath, 4B to stent thrombosis, and type 5 related to cabbage. So, troponin leak. Do we use the term troponin leak a lot here? We had a fun conversation with the cardiologist yesterday. They're struggling with this at Vanderbilt. They don't know what to do with this. The type 1 MIs, okay, those are pretty obvious. The type 2 MIs are usually associated with something else that's got your attention. Heart rate's too fast, heart rate's too slow, they're septic, they're in cardiogenic shock, something else, they're thyrotoxic, but you check a troponin and oh crap, it went up. What do we do with this? And it can either be a type 2 MI, but if it's not thought to be based on ischemia, then it can be called non-ischemic myocardial injury with necrosis. One of my dog walking buddies at Vanderbilt is a Vanderbilt, or at home, is a Vanderbilt electrophysiologist. And they had a 35-year-old lady come in SVT. They didn't know how long she'd been in SVT. They checked some troponin and it was elevated. So they cathed her, perfectly stone cold normal coronary arteries. Well, they didn't want to label her as having had an MI. She's 35, she's got normal coronary arteries. So they call it non-ischemic myocardial injury with necrosis. Now, not all of the Vanderbilt cardiologists do that. They see the rise and fall in troponin and they call it a type 2 MI. And then the patient's calling them up later going, did I have a heart attack? And they go, then they fuss at the coders, why did you code it an MI? They said, well, because you called it a type 2 MI. That's why we coded it that. And so this is, troponin leak to me has become the fibromyalgia of cardiology. You know, when you don't know what it is, you call it a troponin leak and hope nobody asks you any more questions about it. So some things that can cause type 2, I wrap the 2 with the snake because these things can sneak up and bite you. Tachycardia, bradycardia, aortic dissection, hypertrophic cardiomyopathy, shock of any type, respiratory failure, severe anemia, hypertension with or without LVH, spasm. Now, I just saw this image of this flaming 2 and I thought that just looked so cool. I had to put that on there. Not everything that causes a troponin elevation is ischemic. Certainly if somebody's in a car wreck or a big barroom brawl, cardiac contusion, surgery, ablation, defibrillator shocks, rhabdo, myocarditis, drugs or chemicals that damage the heart. These last 2 I struggled with a little bit. Sepsis without septic shock. I guess if there's shock, it can cause an ischemic elevation of troponin, but perhaps there are endotoxins produced by the organism that can have direct cardiac injury. And acute pulmonary embolus, I'm guessing from just the strain on the heart muscle, because I used to practice in the emergency department at the Army Hospital at Fort Campbell, so we took care of the 101st Airborne and their families. And they'd put on 60-pound packs and go march for 15 miles, and we'd see all sorts of, muscle enzyme elevations, CPK, due to the strain on their muscles, and we'd have to hospitalize them to keep their kidneys from shutting down. So strain on muscle can cause all sorts of things to leak. Now, in ICD-10, all MIs are coded as ST elevation MIs unless we say otherwise. So if we think somebody has had a legitimate type 2 MI that's not ST elevation, we need to say non-ST elevation so it gets coded correctly. Hypertension, as I mentioned, in ICD-10, there's one code for hypertension. So benign and malignant all get coded the same way. So we have to focus our attention on end organ injuries, encephalopathy, renal injury, heart failure. Mental status, naming the mental status, delirium and encephalopathy. No real good definition of encephalopathy, but when we identify either a toxic or a metabolic encephalopathy, that's a secondary diagnosis at the very highest level of severity. And there's a table that you'll have that has every ICD-10 option to identify an encephalopathy. The ones that are in red are at the highest level of MCC, the toxic encephalopathies, the metabolic encephalopathies. Interestingly, hypertensive encephalopathy is only a CC, not an MCC. I don't understand why. Glasgow Coma Scale. We can code from the Glasgow Coma Scale. From the pre-hospital setting, paramedics, EMTs, if they write down the numbers and we bring them into the medical record, we can use that. But we need to use the number from each of the three categories: eye-opening, verbal response, and motor. And if they meet any of the criteria for the worst things of each category, it's a secondary diagnosis at the level of MCC. But if we just use the total score only, we never get any credit for that. So we have to use the component elements of that when they're severe. Difference in TIA and stroke. When I was born, we were taught that, if symptoms lasted more than 24 hours, it was stroke. If it was less than 24 hours, it was TIA. And it didn't take long to realize that if somebody was still having symptoms at about hour 5 or 6, they weren't likely to get better. And so this study blew that time frame thing just all away, because these were patients whose symptoms went away within an hour. Their TIA symptoms went away within an hour, and a third of them had findings on MRI, diffusion-weighted imaging MRI. And so if you see something on the MRI, that's a stroke. That's diagnosed as a stroke. So that kind of blew that away. Stroke specificity in ICD-10, they can do the anatomic description, mechanism, embolic versus thrombotic. If somebody has atrial fibrillation and a stroke, then we can call that embolic stroke, and they can code that. Now, for late effects of stroke, we see these things and we just acknowledge them, and they're in our face, and we don't write them down a lot, but they can code and give us credit for late effects of stroke: aphasias, dysarthrias, dysphagia, and dementias. They used to, for hemiparesis or hemiplegia, we used to have to use those terms, but if now we can say weakness due to stroke, and they can code as hemiplegia and hemiparesis just by using the term weakness. And left or right, again, we want to know that. And there are also codes depending upon the patient's dominance. If they're right-handed, if they're left-handed, there are codes for that as well. Interestingly, if we give TPA to abortive stroke, it codes to stroke. If we give TPA to abort an MI, it codes to unstable angina. We have brought this to the attention of the coding bureaucracy, and they have put their head in the sand. We don't know why they have that different technique. Cerebral edema is a secondary diagnosis at the highest level of an MCC, as is cerebral herniation. The term midline shift has no credit at all. The radiologists use it all the time, so you need to just develop in your psyche, when you read the word midline shift, when you feel the words forming on your lips, your just bones should shake into herniation. It's herniation. We get no credit for midline shift, we get credit for herniation. And cerebral edema, clinically significant cerebral edema is not inherent to strokes. So when it occurs, if it's noted on the radiologist report, we need to bring that in to the progress note so we get credit for it. These are secondary diagnoses for which we get the highest level. Intracerebral hemorrhage, even if it's an ischemic stroke that has a few punctate hemorrhages, the word hemorrhage is in there, we get extra credit for that. Just the way the system is. Herniation, coma, acute respiratory failure, cerebral edema. Secondary diagnoses at the level of a CC, SIADH, hemiparesis, weakness due to stroke is now codable, aphasia. There's a table of other CCs and MCCs, and a table that tells you words we don't get credit for, we do get credit for. Seizure is a symptom. Seizure disorder is a condition. We get no credit for the symptom of seizure, but for seizure disorder, we do, because it's a condition. Who's heard of functional quadriplegia? Oh, bless your heart. It's the only condition that the coding system defines itself. It's not in the medical literature. If you do a PubMed search for functional quadriplegia, it comes up nothing. But it's defined as the lack of ability to use one's limbs to ambulate due to extreme disability that's not associated with the neurologic deficit or injury. It's not from cord ischemia. It's not from cord transection from trauma. The best example is end-stage Alzheimer's. When somebody can no longer feed themselves, not able to turn themselves in the bed. It's not particularly intensive for us physicians, but it's extraordinarily intensive for nursing care. They're total care patients, and it's just an absolutely incredible imposition on the nursing care, and so the system acknowledges that. So functional quadriplegia, the relative weight in the HCC system is 1.2. Remember, the relative weight of our 65-year-old lady with breast cancer was just a little bit less than this. The metastases was higher, but this is very highly weighted. So let's see what it does if somebody has simple pneumonia, no secondary diagnosis, relative weight 0.7. With an MCC, the functional quadriplegia being the MCC, it doubles the relative weight. And if this patient needs a nursing home bed, bam, here's your expected length of stay that accomplishes that as well. And here's how much increased credit that is. An ST elevation MI has a relative weight of 0.2. Functional quadriplegia is 5 times that. Cerebral infarction due to ischemic stroke, it's 4 times that. Multiple fractures of the pelvis without disruption of the pelvis ring, it's 3 times that. I mean, these are big deals, and it's higher weighted than all of those. Complications of diabetes, obviously, the classifications type 1, type 2, what caused the diabetes, whether it's gestational or not, procedural or not, and due to underlying conditions, and here's a list of underlying conditions that can cause that. And importantly, in ICD-10, if we can link diabetes with the consequences, retinopathy due to diabetes increases the relative weight, autonomic neuropathy due to diabetes, non-pressure ulcer due to diabetes. When we link those, the condition and cause and the condition and consequence, there are often increased relative weights to that. Non-pressure ulcers, pressure ulcers. We're human beings taking care of human beings, so there's a lot of codes for use, abuse, and dependence, and increased credit for dependence with symptoms of withdrawal. And we've got definitions of those. Acute kidney injury. The terms acute kidney injury and acute kidney failure are synonymous in the coding system. Failure makes my brain think they need to be on dialysis, and it's nowhere close to that. To diagnose acute kidney injury, you only have to have a rise in the creatinine of 0.3 above baseline. Or if their creatinine is chronically elevated, 1.5 times above their baseline. And it goes the other way too. If somebody comes in with a creatinine of 1.5 and during the course of hospitalization it goes back to 0.8, well, that's more than a 0.3 rise, so they had acute kidney injury on presentation, and we can get credit for that. Acute renal injury or failure, if we can identify the pathologic mechanism of the injury, not only do we get credit for the acute kidney failure, then it rises to the level of MCC. If we just say acute kidney injury or failure, that's a CC, but if we can attribute it to acute tubular necrosis, then that's an MCC. And most of the acute kidney injury in the hospitalized setting is ATN. Whether it's hypertension or hypotension or contrast-induced, most of that is ATN. Now, with contrast-induced kidney injury, most of that goes away with hydration. If the numbers don't normalize within 3 days, then that's AKI due to ATN, and we get the secondary diagnosis at the highest level of the MCC. With chronic kidney disease, stage 1, 2, 3, we don't get any increased relative weight for that. For stage 4 and 5, we do. The MCC is for irreversible renal disease that requires dialysis or transplant. GI hemorrhage brings us to the concept of acute blood loss anemia. If a patient has a 20% drop in their crit or a fall of the hemoglobin of 2, or if we transfuse 2 units of blood, any of those will qualify for their diagnosis of acute blood loss anemia. But you don't have to have a drop in the numbers to get that. If someone comes in with an acute GI bleed, and we send that first lab test and the numbers come back relatively normal, they can still have loss of RBC mass to qualify for acute blood loss anemia. And this is an example the next day after we hydrate them and their crit drops. This is important to note that it was present on admission, as subsequent numbers may not look as good as the first one, and it applies in trauma as well. It was always a wonderful aha moment for the emergency medicine residents to realize that sometimes you have to transfuse before the hematocrit drops. If there's like a hole in the vena cava due to a gunshot wound, you may need to replace that blood volume before the numbers look bad. Malnutrition, the assessment of that has recently changed. We don't use albumin and prealbumin anymore, and there's an appendix in the handout at the back that explains that. I made slides that explain how that was for my own edification, so I thought I'd be nice and share that. Inflammation can either be present or not present, and when it is present, you can get changes in albumin and prealbumin that can mask malnutrition. So they've kind of gone to something else that's been published by the ASPEN organization. So any two of these 6 criteria, inefficient energy intake, weight loss, loss of muscle mass, loss of subcutaneous fat, generalized fluid accumulation that can mask the weight loss even, and diminished functional status as measured by hand grip strength can go into that. Some terms that we use that we don't get credit for, even morbid obesity, we don't get credit for except when it's the Pickwickian syndrome associated with alveolar hypoventilation. Now, interestingly, the definition of morbid obesity is a body mass index of 40 or greater. If we document the body mass index of 40 or greater numerically, we get an increased relative weight for that. If we just use the term morbid obesity, we don't get increased relative weight for that. That doesn't make any sense, but that's how they've done that. So if the nutritionists identify any level of malnutrition, we get increased relative weight for that as a secondary diagnosis of a CC. If it's severe malnutrition, that's an MCC. And in the HCC methodology, that's very important to us. Any level of malnutrition gives us an HCC code. So that's important to capture those for our own quality of care determinations. Readmissions are being looked at. For the past 3 years, they looked at heart failure, MI, pneumonia, readmission rates. Again, these are risk adjusted, so they look at other hospitals' rates and compare ours to theirs. This year, they're adding chronic lung problems of COPD and chronic bronchitis and joint replacements of knee and hips. The maximum penalty taken away is 3% if your hospital is deemed to readmit in excess of the national average. And that's not just 3% taken off of these diagnoses, that's 3% out of every check Medicare sends. That can add up. But they're risk adjusted. So if we have a patient that's morbidly obese, that has a body mass index of greater than 40, we need to document that so our patients will be compared to other morbidly obese patients. If we leave that off, we lose that comparative edge. Now, this is heart failure, mortality readmissions. These are all the codes they look at to consider readmission of those. Forget those, look at this. These are diagnoses that take heart failure patients out of that bucket that's being considered for readmission or mortality penalty. If we diagnose acute respiratory failure, or if they have a type 2 MI, it takes them out of the heart failure bucket. And we talked with the cardiologist yesterday. The patients that are with heart failure that are more likely to be admitted are these people. So by getting them out of the heart failure bucket does us a favor. It helps our heart failure statistics. And when we take the type 2 MI because of heart failure and put them into the acute MI bucket, they're less likely to die from an MI than the typical MI patient. They're less likely to be readmitted than the typical MI patient. So it helps the numbers in both categories. So by getting the diagnosis right, the hospital's no longer at risk for heart failure readmission or mortality penalties, and we physicians benefit in our quality and cost efficiency evaluations from the higher weighted and correct diagnoses. And it's established that as troponins rise in the setting of hospital, so does the mortality rate. So calling these, if we legitimately think it's ischemic, a type 2 MI may be a benefit. Another issue that arose is that when they go into the MI bucket, there are the core measures, aspirin, ACE inhibitor, all those sorts of things that are required for MI patients. So it's not an easy, straightforward thing. There are some complexities that have to be considered. With pneumonia mortality rates, the average national rate, mortality rate for pneumonia is about 12%. These are 3 hospitals in Hawaii. This one a little bit above the national average. This one spot on. This one a little better than the national average. Again, the diagnostic codes that are under review for potential penalty, but these are the things that take them out of that bucket. If it's a complex pneumonia, such as aspiration, if they meet the criteria for sepsis, for acute respiratory failure, or if they have AIDS, You know, if they've ever had the diagnosis of AIDS or a CD4 count that has a diagnosis of AIDS, they're taken out of that bucket. So again, it puts the hospital at lower risk and gives us the benefit of the higher weighted diagnoses. This is the readmission penalty for Pomona Valley for the past 3 years. Not bad at all. Not really thrilled about the trend there. And here's some of your neighbors. You can kind of see where they are, and some other hospitals of note. Brigham and Women's is affiliated with what I understand now is a fully accredited medical school. But look at University of Pennsylvania Hospital in Philadelphia. They got the maximum penalty. This is an academic medical center. I don't think this is a bad hospital. I think it's probably a pretty good hospital, but their documentation's probably horrible. They just called us a couple of weeks ago. Help us, help us. And Vanderbilt, where I spent so many years. Okay, so we talked about the music mnemonic. We don't have to remember 70,000 codes. We put a condition in here and try to link caused by, due to, resulting in. The 3 rules of 3. We particularly want to remember those things that improved during the course of the hospitalization. We don't want to forget those. Lawyers will tell us that if we didn't document it, we didn't do it. The payers tell us if we didn't document it, you didn't diagnose it. What we say is if it's not documented, you can't get credit for it. We want you to get credit for it. We want our patient's true, total complexity of illness to be thoroughly and accurately described in the medical record using language that the coders can use to give us credit for it. So we don't get down-coded, we don't get payments denied, our quality portrayal is spot on accurate, our cost efficiency portrayal is spot on accurate, and we get the coding specificity required for ICD-10. Michelangelo at age 87 said, "Yet I am learning. If people knew how hard I had to work to gain my mastery, it would not seem so wonderful at all." So completely and totally unofficially from me, unsubstantiated by any certifying organization, if you're age 87 or greater and still practicing medicine, you can ignore everything you've heard. But for those rest of us, we need to pay heed. I thank you for your time. I know I went over a bit, but I hope this was, if not enlightening, at least informative. So at least we'll understand what we need to do, not just to survive, but to actually thrive in these changing environments.